Good afternoon. I want to thank everyone to be here, and thank you, Dr. Porterfield and Dr. Yan, for having me here for our talk. I couldn't find a woman to be on that robot for some reason, so if anyone has it, please send me. But I'm going to talk to you about my perspective, a colorectal perspective in training in robotics. This is my disclosure. I teach and I proctor cases for Intuitive. So, starting with, this is a simple table, right? I like to build, so I just put this out here. But if you're trying to build a table, what are the tools in your toolbox you're going to use? I think, just building any furniture is like doing surgery. You got your little toolbox with, multiple tools, and you have to choose what is the best tool to use to build this table. Same thing we have with surgical tools. You have open, laparoscopic, robotic, TAMIS, multiple tools that you can use. So what do we need to do as teachers, as faculties, in institutions and hospitals? We need to train our residents and fellows to learn all these tools. They need to know how to do open surgery. They need to know how to do laparoscopic surgery. And they need to learn, to use a device that augment laparoscopic. Now, this could be a robotic platform or any other platform, which these are very important, intuitive, and essential. So we have to offer that to our residents. And then, as we, heard from our previous talk, there's so many robots out there. We had the S, then the SI, now we have the XI, SP's out. Then we have others, platforms like Transenterics, Med Robotics, and future we're going to have virtual incision, and so many more. So we got to start somewhere, and we need to teach our residents and fellows. I wanted to start from a laparoscopic aspect. I think there's been a lot of growth in laparoscopic field, but unfortunately, the penetration to colorectal hasn't been that great. And this was a great study that they looked at. Over 3,000 hospitals with more than 93,000 patients, and only 32% of these patients had a laparoscopic colectomy in a minimal invasive fashion. And there were patients that were eligible for minimal invasive, but they didn't have the surgeons with the skills of the laparoscopic, or they didn't feel comfortable to do these minimal invasively. Then we can see that, the penetration, it has been very low nationally. The laparoscopic utilization for colon has been around 40 to 50%, and even much lower for the rectal field, which is about 10%. So, now this doesn't just end here. This is also our young trainee that's coming out of fellowship-trained colorectal surgery programs. And this was a survey from young surgeons, ASCORs, to see the impact of practice environment on the laparoscopic colectomy utilization in their practice. And as you see, it's pretty low. Only 26% they did laparoscopic for right colectomy, even lower for sigmoid, and the LAR and APRs, which is in the pelvis, the rectal dissection, were only about 20%. And when they, asked the reasoning, multiple reasons. One was it wasn't the right patient for them, or lack of a qualified bed assistant, and or there's just personal comfort or expertise. And there's nothing wrong with that. That's the tool they chose. But we see with the laparoscopic, unfortunately, we didn't move very forward. So we do have training. We do require our resident to learn laparoscopic, and they need a certain number. But interestingly, we don't have that for the robotics. And that's what we need to work on. And to overcome, we had a great talk by Dr. Coker about the simulations, but to overcome these problems, we gotta use the simulators. We gotta use our mentors, the courses that goes around. There's a lot of people out there that are trying to teach and help. And, with the nice simulation we have and give feedback you get right away of what you're doing right and wrong, we can start doing that for our robotic training programs. I'm not going to talk about the advantages of the robot, because I know everybody knows here, but it's a digital platform, okay? It allows us to do much more in a minimal invasive way. And I think the benefit for colorectal field specifically, it has reduced our conversion rates. We don't convert to open that quick. And it allows us to do a minimal invasive operation in more complex patients. I see that a very huge advantage for our field. So what was my experience? We didn't have a dedicated robotic program, in my residency. And we did have one or two surgeons who did it. So my experience was, I had to I had to be perfect in laparoscopic, so I had to learn laparoscopic first. Then I had to do the online module, complete all what was needed with the proof to my faculties, did a lot of bedside, and finally I was get on the console. And I was actually one of the first residents that got on a console in my program. So that's what I tell my residents when, I was working there. And in fellowship, I had to show that, hey, I can do minimal invasive, I can do laparoscopic surgery. And then I was in with Dr. Basturas, which I was actually lucky enough to be one of the pilot program from the Associate Program Director of Colorectal Surgery. They actually built a program in 2015-16, which I think 10 programs was invited and 7 showed up with 14 residents. So I was one of those 14 residents. So we had to do this full thing as far as, with the simulation, bedside, and then also on the console. And I was actually did more than 60, 70 cases that year. So it was a very good experience. And I think it has goals with, and you get the feedback right away of how you're doing in the process. So pretty much is the basic, training, the way the training program was. Then it's advanced, and then you get your certification. The basic training is usually at your own institution. And the advanced, you go out, you go to the cadaver lab, and you do a lot of simulator work, and you actually log your cases. And for certification, you have to do more than 20 consult cases, more than 10 bedside, and you get a letter from your program director. So, as we discussed, this was, this curriculum was established in 2016, which 14% of, residents participated, and it's been growing. It's been great. 2016 to 17, 41% trainees actually entered the data, and the average mean case for the fellows were about 27 cases in each institution. And in 2018, over 85% of residents which are the fellows I'm talking about, participated. And 76% of those fellows are now using robotics in their practice. So this is fantastic to be able to do more minimal invasive. And this slide just to show you how we're growing, in a colorectal field of utilizing robotic mode, and there is a little bit of decrease in the laparoscopic because we feel more comfortable with that platform. And there's been multiple studies, and the studies are growing to give reasoning of why it's been used. So this was also a nice editorial as far as the growing use of robotic training in colorectal surgery. Dr. Disper around 2011 actually established the first colorectal residency curriculum, and they surveyed these residents in 2013 to 16. It was 18 questions to see how they changed their practice. The group that was actually in the training program versus the ones that were not. And interestingly, there was no difference in their laparoscopic approach and cases. They did decrease open operation, and interestingly enough, they increased doing rectal resection compared to open with the robot. So that kind of showed, we know rectal dissections are pretty complex, so they were using more complex, using robot in more complex cases. And the barriers that the ones that did not use were most of them, about 28%, they chose to do laparoscopic, no problem with that, or they had inadequate training, about 20% of them, inability to get the consult time, or they didn't have any block time in their institution. These were some of the limitations they had. So I think, training is a key. This, the robotic is actually giving you this technical changes that we can gear away from open operation. Everything has its limitation. With laparoscopic, we talked about the 2D visualization and using instrument in a more restrictive pattern. But you know, robotic has its own, the console. It's kind of being away from the patient. Some people don't like that. You know, they want to be by the patient, so that's one. Or you don't have any haptic feedback. Hopefully those in future, you know, we're going to overcome those problems. But these are some. So you need actually a training program to, you know, train the residents, the fellows, the surgeons of how you do these. And you can do that with online modules, simulators, centers that teach it, you know, and a lot of centers have dual console. How many have dual consoles in there? That's good, that's great. So it's not like the surgeon or the faculty standing aside and the resident is doing, you can actually, you know, teach them at the same time. And the robotic courses that's going all around, which is fantastic. So the main components of the robotic colorectal surgery training, to me, I think number one, the resident needs to know the operation, right? So it's hard to teach two things. You're teaching a new platform, but at the same time, you want to teach them how to do sigmoid colectomy. Be in this plane, but hey, use this. So know the operation, that's the first step. Then know the equipment, that's the next step with the robot. And then using the techniques to optimize the equipment for that specific clinical scenario that you're performing. So robotic surgery is a tool. It's a great tool, okay? That's allowing colorectal surgeons to perform laparoscopic surgery better and in a more complex matter. And these new technology, as they become incorporated into the medicine, we gotta find a way to utilize them you know, with safety and effectively. And in order to do these, we talked about we have to have a structured program, and we got to have competence in using these instruments safely. And surgical simulation should be complementary to the standard surgical training. And with the future, with all the new technology and the software that's coming, we need to incorporate all of that. And hopefully we'll find a good curriculum, but we don't have anything great yet. This was my past with Dr. Bastura sitting next to me. This is the dual console we talk about, and this is our future with our residents and, you know, doing operation. Thank you.